Alan briefly touched on the triad of impairments and the instruments that are used for diagnosis, the ICD-10 and the DSM-5. But why have a diagnosis? What are the benefits? These days people tend to talk in a negative sense about having a label, but it's worth mentioning that in general the ASD diagnosis is quite robust. There's a high agreement rate between diagnosticians, and for many people the ASD diagnosis comes as a relief. So I'd like you to, just in pairs, think about the benefits of having a diagnosis and also discuss who you think makes the diagnosis. If you take 5 or 10 minutes for this task, and then we'll feed back as a group. So, there are many benefits of the diagnosis. It provides information to parents and caregivers. It gives pointers for treatment, interventions. Indeed, it's been shown that the earlier an intervention is utilised for those with ASD, the better the outcomes for them in later life. So it's really important to obtain the diagnosis. It also enables people to link with appropriate support groups, be it the National Autistic Society or parent groups or specialist ASD provisions. And from an education perspective, it enables children to have access to the specialist education provision and specialist resources. So who makes the ASD diagnosis? How do you go about getting one? If you've got a child in your class who you may think have ASD, what are your next steps? In Scotland, it's generally agreed that diagnosis should be made by multidisciplinary teams, and the Scottish Intercollegiate Guidelines from 2007, there were a lot of recommendations about people being diagnosed earlier. In 2011, the Scottish Autism Strategy made further recommendations regarding diagnosis. Some of those were better training for professionals in the use of certain diagnostic tools, such as ADOS, the Autism Diagnostic Observation Schedule, the ADIR, Autism Diagnostic Interview Revised, and DISCO, Diagnostic Interview for Social and Communication Disorders. There were also recommendations to address waiting lists for assessments and for more evidence-based approaches for diagnosis. So you may have heard of some of these tools, the ADOS, the DISCO, the ADIR. Another one you may have heard of is GARS, the Gilliam Autism Rating Scale. In response to general recognition that there were many gaps in service provision, gaps in experienced personnel, and also to address those who'd often fallen through the net for a diagnosis, the National Diagnosis and Assessment Service for ASD was set up in Alloa, Scotland. It hopes to provide accurate diagnosis and assessment. They believe that specialist, multidisciplinary diagnostic and assessment services for ASD should be available in the local area. The service is run by Professor Tommy Mackay, and he has 30 years' experience in the diagnostic process. They operate an open referral system. Anyone can use it, so that could be parents, GPs, prison services, education services. Assessments of individuals are normally carried out at their premises in Alloa, but they also visit individuals in different settings, such as at home or at the school. It's worth mentioning here that in an educational setting, educational psychologists are often a valuable resource regarding our ASD diagnosis. So Alan mentioned the triad of impairments, which involves difficulties in social interaction, difficulties in communication, and restricted repetitive interests. The ICD-10 and the DSM-5, they go into more detail about the triad of impairments, but I'd like to do another paired activity where you discuss with your partner how you think the triad of impairments can present itself in a school setting. Again, if you take 5 or 10 minutes, and then we'll feed back as a group. So firstly, if we look at difficulties in social interaction. In a school setting, we could see children who don't have many friendships with their peers, children who are alone in the playground, they may be withdrawn, they maybe have difficulty sharing, doing group work, they may fall out with their peers, they may be bullied. When we look at difficulties in communication, we could have difficulties with developing speech, language difficulties, difficulties with reading and writing, difficulties with greeting appropriately, sharing information that is appropriate. Also, they may not be able to change their communication to suit the listener, so they might use overly formal language, especially in someone with Asperger's syndrome. They might talk the same to children as they do to adults. They might talk the same in the classroom as they do in the playground. They may have difficulty with storytelling. They might have difficulty taking turns in conversation. And they may not know how to use verbal and non-verbal signals and have difficulties understanding what is not explicitly stated. So, for example, inferring meaning, non-literal or ambiguous meanings of language, or they may have failure to initiate or respond to social interactions and a lack of facial expressions. If we look at restrictive and repetitive interests, they may have stereotyped or repetitive motor movements. So they may have finger or hand flapping, they may flip objects, they may have difficulty moving from one task to the other, so difficulty from moving from English to maths. They may have a fascination with objects. They may insist on sameness, insist on sitting in the same place, insist on using the same pencil. They may find it difficult to adhere to routines. There are a lot of routines in a mainstream classroom. They may experience extreme distress at small changes. They might have a change of teacher. Someone different might be picking them up from school. They might need to take the same route to school every day. They might eat the same thing for lunch every day at school. They may also have a strong attachment or unusual occupation with certain objects or certain subjects. They might be obsessed with, say, dinosaurs, and that's the only thing that you could get them to do at school. They also might have problems with organisation and planning. So with that comes timekeeping, being late for school, forgetting their homework, forgetting their school bag, forgetting their pencil case, forgetting their pencil. They may also have difficulties with sensory input. The ICD-10 mentions hypo or hyperreactivity to sensory input, so they might feel the need to smell things, to touch things more than other people. They might have an underreactivity or overreactivity to pain. They might react strangely to certain textures or to a change in temperature in the room. If we look at the ICD-10 diagnostic criteria, we have the heading Autism Spectrum Disorders, and off of this heading we have three categories: Asperger's syndrome, childhood autism, and atypical autism. With childhood autism, the criteria is that the onset of the triad of impairments is usually before the age of 3. With Asperger's syndrome, we still have the triad of impairments also, though there is generally no cognitive or language delay in people with Asperger's syndrome. With atypical autism, this tends to be a category that's not used so much, and it actually won't appear in the next edition of the ICD, which is due to be published this year. If we look at the DSM-5, we again have the Autism Spectrum Disorders heading mentioning the triad of impairments. The Asperger's syndrome diagnosis has disappeared from the DSM-5, and this has caused controversy. Some people have argued that the AS diagnosis has always been a grey area. It's never been a robust diagnosis. It's argued that some people miss out on a diagnosis with the DSM-5, whereas they would have had one with the DSM-4. There's also always been controversy between high-functioning autism and Asperger's syndrome, and whilst there are distinctions between the two, there is debate as to whether this is clinically significant. So Alan also mentioned comorbidities, learning disabilities in those with autism. Autism often overlaps with other conditions. The highest overlap tends to be with attention deficit hyperactivity disorder, but it can also overlap with semantic pragmatic language difficulties, dyspraxia, tics, Tourette's, epilepsy, disorders of attention and perception. It also overlaps with genetic conditions such as Fragile X, tuberous sclerosis and Down syndrome. Gilbert argues that coexistence of neurodevelopmental disorders and sharing of symptoms across the disorders is the rule rather than the exception with ASD, and he encourages us to think of ASD as not being one distinct condition. And so a lot of people with ASD have a learning difficulty that is an IQ lower than 70. Though it is worth noting that more people with high-functioning autism are being diagnosed. I actually have a friend who was diagnosed a couple of years ago at the age of 41 with Asperger's syndrome. And the percentage of those with a learning disability, it used to be thought of as being about 75%, but more recent studies suggest that it's thought to be about 50%. I'd also like to mention subgroups on the spectrum. There are many subgroups on the spectrum that are thought to exist, and there are thought to be 2 subgroups for females with ASD. It's argued that females often miss out on an ASD diagnosis, or they tend to receive a diagnosis later on in life. As Alan mentioned, it's recognised that there are more females at the lower functioning end of the spectrum, and in this particular subgroup there is a higher comorbidity of epilepsy, a higher still one for low functioning autism, autism spectrum disorder, and epilepsy. As Alan also mentioned, the ratio of male to female ASD is generally thought to be about 5 to 1. The recent studies have shown that these ratios have narrowed. One such study shows that at the lower end of the spectrum, the ratio is more like 2 to 1. Also for Asperger's syndrome, the ratios were generally believed to be about 9 or 10 males to 1 female, but again there are more recent studies showing that these ratios have narrowed. Recent research has shown that ASD in females manifests itself in different ways to males. It's argued that females are actually better at masking the social symptoms of ASD, but they suffer from greater impairment in this area. Also, that they demonstrate more appropriate play behaviour than boys. Indeed, I work with a girl with Asperger's syndrome who, when she was at primary school, coped really well academically and presented as coping well socially, but at home her behaviours became increasingly challenging due to the fact that she was struggling with her peers. And the older she became, the more it became evident that she struggled with peer relationships. In fact, she was the victim of quite a traumatic bullying incident. And so due to this altered presentation of ASD in females, there is also a need for more female-friendly diagnostic tools. Kopp and Gilberg in 2005 actually created such a tool. With high-functioning autism, there is an argument that females miss out on diagnosis with the DSM-5, whilst they would have had a diagnosis with the DSM-4. So it's important to look out for these particular subgroups in our classes. I also want to mention sensory conditions. Sensory anomalies were mentioned by Kanner in 1943. A welcome inclusion into the DSM-5 criteria is the addition of unusual sensory behaviours as a core diagnostic criteria. Studies have shown that up to 70% of people on the spectrum have sensory anomalies, and there's more at the higher end of the spectrum. The most common ones are to do with underreactivity to pain and overreactivity to sound, where the most commonly affected with sensory processing subtypes have also been found in those with ASD. And the understanding of these is important in providing early intervention to reduce severe autistic symptoms in later childhood. 3 distinct subtypes have been found: SBIS, which stands for Sensory-Based Inattentive Seeking, SMMS, which stands for Sensory Modulation with Movement Sensitivity, and SMTS, which stands for Sensory Modulation with Taste Smell Sensitivity. They're distinguishable from each other in terms of their severity. SBIS tends to be less severe than the other 2. It's been argued that identification of these can guide intervention approaches. There is another diagnostic criteria that's important to consider. It's worth mentioning that although we tend to think that there are 5 senses, taste, touch, smell, hearing and vision, there are actually another 2 senses: proprioception, which means our sense of body position, and vestibular, which means our sense of balance. So it's important to think about all of these 7 senses when thinking about hypo or hyperreactivity to sensory stimuli. So, thanks for listening. I've attached some useful references and contacts on further slides, and I'd now like to pass you on to Nicola. She will talk about the different cognitive theories that try to explain the different behaviours and triad of impairments related to ASD.